Assalamu alaikum. Beta, in this video lecture, I will deliver the lecture on precision medicine, the introduction to precision medicine and the gene-based therapies. It's a bit lengthy lecture, but it's really important lecture for your clinical and the basic genetics. Referring to this lecture, beta, what is precision medicine by definition? If I keep it simple, beta, I have discussed something about this precision medicine in the previous lectures, if I'm not wrong, in the cancer genomics and the basics. Beta, precision medicine refers to the medical treatment, the medical interventions that are very much specific for a specific individual at the particular time, depending on their characteristics, their risk factors, the biomarkers of the disease. ओके, तो बेटा एक इंसान को उसकी डिज़ीज़ के मुताबिक और उसकी जो करेक्टरिस्टिक्स हैं, डिज़ीज़ के रिस्क फैक्टर्स हैं और जो जितनी भी चीज़ें हैं उनके मुताबिक उस इंडिविजुअल को कौन सा ट्रीटमेंट दरकार है और उसको वही स्पेसिफिक ट्रीटमेंट प्रोवाइड करना इज़ द प्रिसिजन मेडिसिन। और इस प्रिसिजन मेडिसिन को बेटा डेवलप करने में बहुत सारी चीज़ों का रोल है जिसमें बेटा recent advances in the genomics, data analytics and AI, that is the artificial intelligence. These three things, the recent advances in the genomics, data analytics and the AI, they are very much like important things to develop the precision medicine. And what is precision medicine? The medical treatment, medical intervention geared towards the characteristics of the each individual patient. एक पेशेंट को एक वक्त में उसकी बीमारी से मुतल्लिक कौन सा ट्रीटमेंट चाहिए और उसको वही स्पेसिफिक ट्रीटमेंट देना इज़ द प्रिसिजन मेडिसिन. ओके, एंड प्रीवियसली इट वाज नोन एज द इंडिविजुअलाइज्ड और द पर्सनलाइज्ड मेडिसिन. ओके, and using the precision medicine you can treat the specific disorders like monogenic disorders, the disorders which involve the single gene, that can be the spinal muscular atrophy SMA, it can be the Duchenne muscular dystrophy DMD, it can be the retinitis pigmentosa RP. This is a important thing बेटा, this is important in itself के अलग से भी क्वेश्चन पूछा जाता है आपके एग्जाम्स में कि which one is the monogenic disorder, so you can remember at least these three, SMA, Duchenne muscular dystrophy, DMD and the retinitis pigmentosa. These are the monogenic disorders where you can apply the precision medicine and you can treat these. Okay, not only the monogenic disorders, but some cancers and some polygenic disorders can also be treated using precision medicine. So let's see. Yeah, you can see here some cancers and the polygenic disorders like diabetes, IHDs, that are the ischemic heart diseases that can be treated. So cancers and the polygenic disorders that involve the multiple genes, they can also be treated. Okay, this thing is not for your real purpose. Okay, so let's go to the medical application of the precision medicine. For that we have an example of, let's suppose we can talk about spinal muscular atrophy. Okay, we will then talk about the Duchenne muscular dystrophy and the Becker muscular dystrophy. Okay, so starting with the spinal muscular atrophy SMA, it's not a really common thing, but it is its incidence is little lower, that is 1 into 11,000 live births. 11,000 बच्चों में से किसी एक बच्चे को होती है. एंड इसमें क्या होता है बेटा, स्पाइनल मस्कुलर एट्रोफी में आपको बहुत, मैं इसकी बेसिक पैथोफिजियोलॉजी से लेके चलूँ तो एक्चुअली क्या होता है बेटा, मैं यहाँ पे समझा दूँ क्विकली, फिर आपको मैं यहाँ से दिखाता हूँ. देखें, नॉर्मली क्या होता है बेटा, एक आपकी बॉडी में जीन होता है जिसका नाम है SMN1 और एक जीन होता है जिसका नाम है SMN2. ओके, अच्छा, जो SMN1 जीन होता है इसका काम होता है SMN प्रोटीन बनाना और इसका काम भी होता है SMN प्रोटीन बनाना. लेकिन एज़ कम्पेयर टू SMN2, जो प्रोटीन SMN1 से बनती है वो क्वांटिटी में ज़्यादा होती है, ठीक है, और जो SMN2 से बनती है वो क्वांटिटी में कम होती है, ठीक है, उसकी वजह क्या है मैं आपको थोड़ा सा बताता हूँ बेटा। उसकी वजह क्या है, जो SMN जीन सीक्वेंस है उसके अंदर कुछ इस तरीके से नंबर होते हैं 1 2 3 4 5 6 7 8। और जो SMN2 जीन सीक्वेंस होती है उसके अंदर जो सीक्वेंस होती है 1 2 3 4 5 6 8। सो नंबर 7 that can be probably a nucleotide that is absent. Okay, so now you understand the SMN1 gene sequence and the SMN2 gene sequence. In case of SMN1 gene sequence there is 7 present, and in case of SMN2 gene sequence 7 is absent. 7 can be obviously a nucleotide, so that is that can be considered as an exon. Okay, so and this is that exon 7, or I can say nucleotide 7, which is responsible for increased SMN production, and this exon 7 is absent in this case, right? Yeah, exon 7 is absent in this case, so therefore there is decreased SMN production from this SMN2. Still there is SMN production, but still there is SMN production, but as compared to this, here the SMN production is little lower. Okay, but at least your body is producing SMN. SMN1 gene is producing enough SMN protein. SMN2 is also producing some SMN, but little lower as compared to SMN1 gene. So by the way, SMN protein is produced in your body. That's it. By the way, SMN protein is produced in your body. And what is the function of this SMN protein? What is the function of this SMN protein? Its function is mainly to to maintain the function of lower motor neurons, ताकि जो मसल की एट्रोफी ना हो, मसल वीक ना हो. देखो बेटा, what is the function of SMN protein? To maintain the function of lower motor neurons. Lower motor neurons actually supply your muscles. So if the lower motor neurons are healthy because of SMN protein, so they will supply the muscles better, and the muscles will not undergo atrophy, they will not undergo weakness. Okay, but just for a second you think about it, if there is no production or very little production of SMN protein, so you think these lower motor neurons will be healthy anymore? These lower motor neurons will not be healthy anymore. So the what will happen then, beta? The lower motor neurons which are present in the anterior horn cells of the spinal cord, they will undergo the progressive degeneration and the loss of the anterior horn cells in the spinal cord and the brain stem nuclei. Okay, as a result your muscle will not get the enough supply and they will undergo atrophy and weakness. I hope you are clear so far, beta. Okay, so let's now read the same thing from here. So SMA is the spinal muscular atrophy. Its incidence is 1 is to 11,000. This disease is characterized by muscle weakness and atrophy, as I told you. And this muscle weakness and atrophy is due to the progressive degeneration and the irreversible loss of the anterior horn cells in the spinal cord and the brain stem nuclei. And बेटा मसल वीकनेस और एट्रोफी क्यों हुई? क्योंकि जो एंटीरियर हॉर्न सेल्स हैं स्पाइनल कॉर्ड में और ब्रेन स्टेम न्यूक्लियाई में उनकी डिजनरेशन हो गई. उनकी डिजनरेशन क्यों हुई? डिजनरेशन तो होनी थी बेटा, क्योंकि SMN प्रोटीन नहीं बन रही. SMN प्रोटीन नहीं बनेगी तो योर लोअर मोटर न्यूरॉन्स विल नॉट बी हेल्दी एनी मोर. सो इफ देयर इज नो SMN प्रोटीन, so there will be nothing to nourish them, so there will be degeneration of the anterior horn cells. Okay, once there is degeneration of the anterior horn cells in the spinal cord and the brain stem nuclei, so lower motor neurons are not working. That means, so they are not actually supplying your muscles, so muscle will undergo atrophy and weakness. Okay, and SMN1 gene, I told you it produces the protein that is obviously essential for the lower motor neurons. But SMN2 gene produces the smaller protein and less stable protein, may partially compensate for loss of SMN1 protein. So SMN1 gene beta, SMN1 gene produces the SMN protein, and SMN2 gene produces the SMN protein. So we can name it actually, the SMN1 gene produces the SMN1 protein, SMN2 gene produces the SMN 2 protein. Both are similar, but the difference is SMN1 gene produces sufficient, more active, more stable SMN1 protein. SMN2 gene produces SMN2 protein which is not that stable, not that functional as compared to SMN1 protein, but still SMN2 protein can compensate for SMN1 protein in cases if this is not present. If let's suppose there is genetic mutation in the SMN1 gene, if there is genetic mutation in the SMN1 gene, you think this protein will be produced. This will not be produced anymore. But if this gene is intact, this gene will produce SMN2 protein, which will obviously try to compensate for SMN1 protein, and it will surely compensate, but not completely, because SMN2 protein is actually similar to SMN1 protein, but still it is not enough to completely compensate for SMN1 protein, right? So now spinal muscular atrophy is the condition in which your SMN1 gene is not working. Therefore, SMN1 protein is not being formed. And because SMN1 protein is not being formed and SMN2 protein cannot completely compensate, it can compensate a little, it cannot completely compensate. So ultimately you have very little SMN1 protein or no SMN1 protein, and the compensation is very little. So there will be progressive degradation and the loss of the anterior horn cells in the spinal cord and the brainstem nuclei, and there will be no supply to the muscles, so muscle will undergo atrophy and weakness. I hope you are clear with this, beta. Right? So what should be the treatment, beta? What should be the treatment in this case? Either we can bring the SMN1 gene back, or we can make the SMN2 gene work completely like SMN1. अगर हम इनमें से बेटा दो में से एक ही चीज़ कर सकते हैं ना इसको ट्रीट करने के लिए, या तो SMN1 जीन को हम वापस ले आएँ जीन थेरापी करके, या SMN2 प्रोटीन को बिल्कुल SMN1 जैसा बना दें ताकि वैसी की वैसी प्रोटीन बनने लगे। तो खैर अब देखते हैं इसका क्या ट्रीटमेंट होता है बेटा। पास्ट में बेटा जो इसका ट्रीटमेंट होता था वो सिर्फ सपोर्टिव केयर होती थी, इसका कोई ख़ास ट्रीटमेंट बना नहीं था। Mostly children with type 1 and type 2 SMA, they died earlier because of no treatment from aspiration pneumonia and the respiratory failure because of the respiratory muscle weakness. And there used to be the huge financial and the emotional and the psychological burden on the families, obviously because of this disease. But in future, my son, there is the treatment for this. There is a complete treatment for spinal muscular atrophy. What is that treatment? The treatment is quite interesting. The treatment is, what we can do is we can make this SMN2 protein work completely like SMN1 protein. We can make this SMN2 gene work completely like SMN1 gene. And you know now, beta, what is the difference between the SMN2 gene and the SMN1 gene? I told you earlier there is just a little difference in the sequence of these two. The difference is of exon 7 only. I hope you got some point. If we can add exon 7 in this SMN2 gene, we can make it completely look like SMN1 gene. And SMN2 gene will later work, in the fashion completely like SMN1. So it will later start producing, sufficient SMN protein. So if I take you a little back here, I told you that SMN1 gene having exon 7 and SMN2 gene is just lacking exon 7. This is the reason SMN produces lots of SMN1 protein and SMN2 produces a little lower and less functional, less stable protein. तो अगर हम क्या करते हैं इस SMN2 के अंदर exon 7 ऐड कर दें तो इसकी सीक्वेंस बिल्कुल इसके जैसी बन जाएगी और SMN प्रोटीन भरपूर आपके पास बनने लगेगी and your spinal muscular atrophy will be treated. So let's see how can we do this, beta. How can we do this? Yeah. So in the present, the treatment is splicing modifiers and the gene therapy. Splicing modifiers is that actually what I'm talking about, the addition of the exon 7 into the SMN2 gene sequence. Or we can perform the gene therapy, that is your SMN1 gene is mutant, it is not working. Get that gene out, throw it out and add new SMN1 gene. That's a simple agenda, okay? So here I will talk about the SMN2 splicing modifiers, in which you will come to see that okay, that this is SMN1 gene sequence in which there is 1 2 3 4 5 6 7 8, and then is the SMN2 gene sequence where there used to be 1 2 3 4 5 6 8. So because this is lost, so we have to make this look completely like this and work completely like this. We have to just add in exon 7. So let's now see how can we add exon 7. This procedure is called SMN2 splicing modifiers. Splicing modifiers. We can add in exon 7 by using some drugs beta. We can add on here by using some drugs. Let me tell you how and where. Um, the exon skipping treatments for SMA to modify the SMN1 gene. Actually, yeah, SMN1 gene to produce a functional survival motor neuron protein. Let me tell you what are those drugs actually, beta. Let me tell you. Yeah, one is beta. Okay, one is right there. That is the nusinersen. Nusinersen, that is actually comes in the compound formulation of the Spinraza, and another is the Risdiplam that comes in the compound formulation of the Avrastai. Okay, these two are the drugs. Right, they two are the drugs. They can help you add in exon 7 and make your SMN2 gene completely look like SMN1. So you can have sufficient SMN1 protein production. Okay, so how do they work? They just modify the SMN2 gene to include the exon 7, increasing the SMN2 protein production. Similarly, this Avrastai compound formulation works. It modifies the SMN2 gene to include the exon 7, and thus including and increasing the SMN protein production. Okay. Beta, these treatments have shown the significant improvements in the motor function, muscle strength, and the survival in the SMA patients. Obviously, because beta we are including the exon 7, so as a result, you will be having sufficient and enough completely active SMA protein. So this will surely treat your condition. Okay, and this is all about beta spinal muscular atrophy. I hope you are clear with the concepts. It's quite easy and interesting. After this SMA, there is another concept of muscular, yeah, muscular dystrophy. Yeah, one is the Duchenne muscular dystrophy and other is the Becker muscular dystrophy. I'll talk about this better. There comes the concept of beta after SMA. There comes the concept of the muscular dystrophies. Okay, muscular dystrophies that include the Duchenne muscular dystrophy (DMD) and the BMD, that is the Becker muscular dystrophy. DMD is the Duchenne muscular dystrophy that is characterized by the completely abnormal dystrophin protein, and BMD is characterized by the presence of not the completely abnormal dystrophin protein, but there is partially functioning dystrophin protein and partially abnormal dystrophin protein. So obviously BMD is less severe as compared to DMD. DMD is characterized by some genetic mutations including the nonsense and the frame shift mutations, and the BMD occurs due to in-frame mutations. But the difference between the frame shift mutations and the in-frame mutations is the both are almost similar, that in case of frame shift mutation there is addition or deletion of the one or more nucleotides, and in frame mutation is also the addition or deletion of one or more nucleotides. But the difference is, as a result of frame shift mutation, the entire transcript or the entire reading frame is affected, is altered. But in case of in frame mutation, the entire reading frame is not altered. Okay, the transcript is not changed that much, right? So this is the underlying pathology of the DMD and BMD beta. So how can we really treat this beta, DMD and BMD? Okay, as I told you beta, that you know DMD occurs due to the frame shift mutation, then BMD due to in frame mutations in the genes encoding the dystrophin protein. So the treatment option should be beta. If let's suppose you develop the DMD, if you develop the DMD, so that means there is in the dystrophin protein gene there is frame shift mutation. Okay, and frame shift mutation is characterized by the addition of the nucleotides, one or more nucleotides that completely change the reading frame. So what should be the treatment option? The new nucleotides which are actually added as a result of the frame shift mutation just exclude out those extra nucleotides, and your coding sequence will get back to the normal and you will be producing normal dystrophin protein. That's it. So this is how we can treat it. Look here, exon skipping is a genetic therapy approach for DMD. जो एक्स्ट्रा एक्सॉन ऐड हुए हैं as a result of frame shift mutation, you just need to skip it out, you just need to exclude it out, okay, to produce a functional and there will be a little shorter and shorter dystrophin protein. Obviously the protein will be little shorter, which will be produced after exon skipping, because you are just skipping out a particular sequence, but still it will be much better and the functional protein. Okay. By the way, DMD itself is characterized by the deficiency, complete deficiency, or we can say not the complete deficiency, but the abnormal dystrophin protein. So DMD is a severe genetic disorder causing the progressive muscle weakness and the degeneration of the muscle. By using the exon skipping technique, like exon skipping techniques like antisense oligonucleotides or mask specific exon sequences, so these techniques we can use, you know, um, these techniques can be used to remove those extra exons, to skip those extra exons, okay, during the mRNA processing. This will allow the production of the little shorter but functional dystrophin protein. Okay, and if you have your functional dystrophin protein back to the duty, it will increase the muscle function and it will reduce the muscle damage. Okay, there are several exon skipping drugs as well, such as eteplirsen, that comes in the compound formulation of exondys 51, and golodricin, that comes in the compound formulation of the Vyondys 53. They have received the FDA approval for the treatment of the DMT. Okay, yeah, that's it beta. These medications actually target the specific exon mutations जहाँ पे frame shift mutations हुई हैं और उनको exclude out कर देती हैं, and you then get your dystrophin protein functional, and when you have normal dystrophin protein, it will improve the muscle function and it will reduce the muscle deterioration. I hope you are clear with the beta concept of DMD, BMD, and the techniques which can be used to get rid of that beta, right? And end of this lecture comes the small interfering RNA. Small interfering RNA, these are the types of RNA molecules. It's necessary to understand about this nice little molecule. It's a type of RNA molecule that plays a key role in regulating gene expression. Small, interfering RNAs, they are like double-stranded RNA molecules. They are double-stranded RNA molecules, and they have almost around 20 to 25 nucleotides, 20 to 25 nucleotides, and they are complementary to a specific messenger RNA. आपकी DNA से जो messenger RNA बनता है उसका ये complementary होता है आपका small interfering RNA. ठीक है, yeah. So here you can read this. Look, siRNAs, that are the small interfering RNAs, they are short double-stranded RNA molecules. They are made up of 20 to 25 nucleotides, and they are complementary to your specific mRNA. Okay, so small interfering RNAs, they work by binding to the mRNA, leading to its degradation and thereby preventing the production of the corresponding protein. अगर उस mRNA के अंदर कोई जेनेटिक म्यूटेशन मौजूद थी और आपने बेटा siRNA यूज़ करके उस mRNA को डिग्रेड कर दिया, तो अब वो mRNA ही नहीं रहा, या वो पर्टिकुलर उस mRNA के अंदर मौजूद जो जीन था वो ही डिग्रेड हो गया, तो वो म्यूटेशंस आगे ट्रांसफ़र नहीं होंगी और जो प्रोटीन एबनॉर्मल बननी थी अब वो नहीं बनेगी. क्यों? क्योंकि उस RNA के अंदर जो एक्चुअली जो mRNA बना था DNA से बेटा, उस mRNA को आपने, अब मैं यहाँ पे भी अगर समझा दूँ कि देखें आप क्विकली DNA से आपका mRNA बनता है। फ़र्ज़ करें कि DNA में कोई म्यूटेशन थी जो कि इस mRNA में आ गई, और इस mRNA में अगर कोई लेट्स सपोज म्यूटेशन आई है तो ज़ाहिर है जो प्रोटीन बनेगी वो भी एबनॉर्मल होगी। अगर हम क्या करें बेटा कि इस mRNA के अंदर जो म्यूटेशंस हैं उसको निकाल के फेंक दें, उन जीन्स को या इस पूरे mRNA को ही डिग्रेड कर दें, तो फिर आगे एबनॉर्मल प्रोटीन्स नहीं बनेंगी। तो इनको डिग्रेड करना तो वही करेगा ना जो इसका कंप्लीमेंट्री होगा, एंड दैट कम्स द small interfering RNA. Okay, so by this you can prevent so many diseases, that have some genetic backgrounds, right? I can take you directly to the examples, like comes the concept of clinical applications of the small interfering RNAs include the treatment of the myotonic dystrophy. मायोटोनिक डिस्ट्रॉफी में क्या होता है, CUG जो न्यूक्लियोटाइड्स हैं वो बहुत ज़्यादा एक्सपेंड हो जाते हैं रिपीटेडली, CUG, तो जब आप स्मॉल इंटरफेरिंग RNA देते हैं तो जो एक्स्ट्रा रिपीटेड CUG हैं उनको रिमूव कर देता है, और जो प्रोटीन बनती है बाद में फिर वो नॉर्मल बनती है। ठीक है, इसी तरीके से एक और डिसऑर्डर है, दैट इज़ द एमायोट्रॉफिक लेटरल स्क्लेरोसिस, दैट इज़ कैरेक्टराइज्ड बाय हेक्सा न्यूक्लियोटाइड एक्सपेंशन। ठीक है, हेक्सा न्यूक्लियोटाइड expansion. This is also characterized by the repeatedly appearing, repeatedly appearing nucleotides, six nucleotides expansion repeatedly. Okay, so using small interfering RNA, you can exclude out these extra nucleotides, and once these extra nucleotides are removed out, then the protein produced will be normal for sure. हंटिंगटन डिजीज जिसमें CUG नहीं CAG एक्सपेंशन होती है, तो जो CAG एक्स्ट्रा ऐड होते जाते हैं उनको स्मॉल इंटरफेरिंग RNA निकाल के फेंक देता है और आपकी प्रोटीन एज ए रिजल्ट नॉर्मल बनती है, एंड यू गेट रिड ऑफ हंटिंगटन डिजीज। अनदर डिजीज इज द स्पाइनोसेरिबेलर ataxia. It is also characterized by CAG expansion, and then with the help of small interfering RNA you can remove out these extra nucleotides, beta. I will continue this lecture, beta, hopefully in the part 2 video. Thank you so much, beta.